Good afternoon to all. We have an exciting afternoon of wonderful talks on vestibular schwannoma management, from observation of tumors to salvage surgery and patient nerve outcomes. Ravi, Samy from the University of Cincinnati, Esther, Vivas will also be moderating today. We'll lead a session at the end on the discussion. Thanks to the program committee for all your hard work and dedication. Congrats to Dr. Alex Lurie for his Neurotology Fellow Award. A few housekeeping items. We'll stay on time. Each talk is 6 minutes. Questions at the end of the session. We have 10 minutes for discussion. And speakers, please state any conflicts of interest you may have. Finally, if any of you, especially those who are international attendees, and us, please Kristen contact info. Thank you very much.
All right. Good afternoon, everyone. My name is John Marinelli. I'm excited to share a little bit about this project that we think is the beginnings of a little bit different way to think about the observation management paradigm. So the title of my talk is Natural History of Growing Vestibular Schwannomas During Observation. It was a multi-institutional study across the United States and Denmark. I have nothing to disclose. So I just want to start the next 6 minutes by framing this talk by the overarching question, the primary question that we attempted to address when conducting this study. And that question is, can we safely continue observing a growing tumor? And at most centers across the world, right now, if a tumor's been shown to grow, that typically begets treatment. And for that reason, there's really very little data that characterizes the natural history of a growing tumor. That is to say, what happens to a growing tumor, or a tumor that's been demonstrated to grow during observation? The reality is we don't have much data to answer that question, mainly because of the existing management paradigm. Now, before getting into the study, our study specifically, I want to bring up this concept that we've called, or coined, the paradox of the observation management paradigm. And I'm bringing this up really for two reasons. One, I think it illustrates that there's probably something left wanting in the current observation management paradigm. But two, I think it really illustrates that the data I'm about to present is quite intuitive. In fact, it shouldn't be viewed as surprising or controversial, but instead maybe an extension of something we already all believe, whether outwardly or not. And so the paradox goes like this. One of the overarching tenets of observation management is counseling patients that not all tumors grow during observation. We tell patients, hey, you may be one of the lucky few that has a tumor that never grows, and for that reason, it may never require intervention. Now, at the same time, what we're talking about here is sporadic vestibular schwannoma. So presumably what we know is that these patients weren't born with their tumor. At some point in their lifetime, their tumor had to grow to the size that it was at the time we diagnosed it. And so in that sense, at some point in a patient's lifetime, everybody had a growing tumor. At some point that tumor grew. And so in that sense, everybody had a growing tumor at some time. And the thing is, with the current management paradigm that we recommend treatment for a growing tumor, it's a little bit paradoxical in the sense, well, if we are going to recommend treatment for a growing tumor, then we should recommend treatment for everybody, because everybody has a growing tumor at some point. And so we believe there's probably something left wanting in the current paradigm. And that's where our study, we believe, starts to come in. And what we did was we combined all observation data across Mayo Clinic Rochester, Vanderbilt, UT Southwestern, and Denmark's national database. And what we said is, let's take the patients that have been demonstrated to have tumor growth already. And the way we defined tumor growth was linear tumor growth by 2 millimeter increase in size between the diagnostic scan and the scan that we picked up growth. So that could be at 6 months, that could be at 3 months, that could be at 10 years. But every time that scan was compared back to the diagnostic scan, and the litmus for a true interval change in tumor size was 2 millimeters. And across about 3,500 patients undergoing observation at the 4 centers, we had about 600 that met this inclusion criteria, where they had demonstrated tumor growth, but for whatever reason, they decided to not undergo treatment. And so we asked the question, what happens to these patients long-term? And specifically, we wanted to look at primarily the subsequent growth-free survival rates. In other words, how many of these patients never end up growing again, at least through last follow-up? So what we found can really be boiled down into this single Kaplan-Meier curve, where at 5 years, you see that about a third of IEC tumors and about a fourth to a fifth of CPA tumors demonstrated no further growth after the time of first detection of growth. So this isn't 5 years from diagnosis. This is 5 years after the time in which we first detected growth. So that could be over 10 years for some of these folks. Interestingly, we had about 100 patients with cerebellopontine angle tumors that elected to continue observing their tumor despite now 2 documented episodes of tumor growth. And about 40% of these folks 5 years after that still showed no growth. And some of these folks now are talking 15, 20 years of observation data that showed no further growth. And interestingly, the strongest predictor of who is going to continue to grow was actually the magnitude of growth between the diagnostic scan and the first scan that picked up tumor growth. So the magnitude of change there, how much it grew in that first intervening period where we picked up growth, was the most predictive factor of whether or not it was going to continue to grow. And we think that makes sense in the sense that maybe it suggests there's some pathophysiologic mechanism behind significant interval tumor growth that's portending a poor risk or a increased risk for treatment failure, or I mean, not treatment failure, subsequent tumor growth over time. And so when you take that all together, or our data, we think fits in with a couple other ideas to make this argument for continued observation. And that argument is fourfold. First being cross-sectional prospective quality of life data show essentially indistinguishable outcomes across the 3 management paradigms where there's not a clearly discernible quality of life benefit of early treatment. Cost effectiveness data actually favors the observation paradigm even among younger patients. And that's something Dr. Rob Masalek, who's going to present in a few minutes from our group, is going to expand on a little bit further. Thirdly, simply detecting 2 millimeters of tumor growth on serial MRI scans is unlikely in and of itself to significantly change, or reasonably significantly change intervention outcomes. And then, as we've attempted to show by these data, not all tumors that are found to be growing necessarily keep growing with time. Thanks for your time.
Hello, everybody. My name is Carly Misztal, and I'm a third-year medical student at the University of Miami. Before I start, I'd like to thank the ANS for the opportunity to present my research today on the effect of AR42 in primary vestibular Schwannoma cells and a xenograft model of vestibular Schwannoma. I have no conflicts of interest or disclosures, and this study was funded in part by the NIH. Vestibular Schwannomas, or VSs, are benign tumors of the cochlear vestibular nerve. Neurofibromatosis type 2, or NF2, is a genetic disease caused by mutations in the NF2 gene that leads to multiple intracranial and spinal tumors, including bilateral VS. This condition can cause hearing loss, imbalance, and decreased life expectancy. Although surgery, radiation, and off-label chemotherapy have been used to treat this disorder, there is no curative treatment. AR42 is a pan-histone deacetylase, or HDAC inhibitor, that is being investigated in the treatment of cancers and benign tumors. In Schwannomas, AR42 disrupts interactions between protein phosphatase 1 and HDAC, facilitating AKT dephosphorylation and halting the mTORC1 pathway, preventing tumor cell survival and growth. A phase 0 clinical trial is ongoing, investigating the role of AR42 in the treatment of meningiomas and Schwannomas. However, the effect of AR42 on preserving hearing and halting tumor growth in preclinical models of VS is unknown. Thus, we hypothesize that AR42 will decrease the viability of patient-derived VS cells and minimize tumor growth and hearing loss in a xenograft model of VS. To determine this, we will measure cell viabilities and protein expression in patient-derived tumors and evaluate tumor growth, hearing, and balance after AR42 treatment of an animal model of VS. First, I will discuss the in vitro portion of our study. Patients undergoing vestibular Schwannoma surgery were consented for tumor harvesting. Tumor chunks were collected from the OR and processed for cell culture and protein extraction. Then, we performed a Western blot to quantify baseline HDAC2 and phospho-HDAC2 expression in tumors. On the right, we show that all tumors expressed are target proteins at varying degrees. So then we wanted to look at AR42 effects on viability using a luminescent assay at 72 hours. We treated cells with vehicle and different concentrations of AR42. We found that AR42 effectively reduced viability by more than 20% when AR42 was greater than 0.5 micromolar. Next, we wanted to look at which VSs responded better than others, so we separated viability by VS. We found some tumors were more susceptible to AR42, specifically VS16, VS18, and VS33. So then we wanted to explore potential reasons for this heterogeneity. We plotted the viability by phospho-HDAC2 expression relative to HDAC2 in a series of linear regression plots. We found strong inverse relationships between target protein expression and drug response at all AR42 concentrations. This was statistically significant, suggesting that VS tumors that express more phospho-HDAC2 may be more responsive to AR42. Because of these findings, we wanted to see how VS will respond to AR42 in one of our animal models. We first cultured mouse Merlin-deficient Schwann cells that were transfected with luciferase. Then we grafted cells onto cochlear vestibular nerves in 19 immunodeficient Rowett nude rats using a post-auricular approach. 2 weeks after tumor implantation, rats were treated with vehicle or AR42 via oral gavage at 25 milligrams per kilogram per day, Monday through Friday with a 2-day holiday. We monitored tumor growth in vitro by administering intraperitoneal D-luciferin and performing bioluminescence imaging. Although the mean bioluminescence measurements in both treatment groups increases by week 6, there were no significant differences in bioluminescence between groups at any time point. To determine whether AR42 can prevent the progression of hearing loss, we measured auditory brainstem response thresholds, or ABRs, at baseline, 2, 4, and 6 weeks after tumor implantation. We showed that both vehicle and AR42 treated rats developed hearing loss over time in the tumor implanted ears. However, AR42 reduced the mean ABR threshold in the first week of drug treatment, or week 2, suggesting that AR42 may delay the progression of hearing loss when compared to vehicle. Although this difference is not significant, it is seen at all frequencies. In the contralateral ear, treatment with AR42 also prevented shifts in ABR thresholds at week 6. However, this was not statistically significant. We also performed rotarat testing to measure balance function in our rats at 0, 2, 4, and 6 weeks. With the rotarat test, beam revolutions increased from 0 to 40 RPM over 300 seconds. We found that the duration of time that rats stay on a revolving beam significantly decreases with time, and we found a similar pattern in the revolutions per minute at time of fall. However, there were no differences between the groups. At the study endpoint, the tumors were harvested and weighed. There was no significant difference in tumor weight between groups, suggesting that AR42 was not effective at preventing the progression of tumor in this model. The limitations of our study include testing of only one drug dosing protocol, small sample size, and the inherent limitations of using a xenograft animal model and transformed cell line, and we hope to address these limitations in future investigations. In conclusion, AR42 may be effective as a targeted therapy for select patients with VS. Although AR42 was not effective in our animal model, further investigations are warranted to determine the impact of AR42 on hearing and tumor progression in individuals with NF2-associated VS. This project would not have been possible without a multidisciplinary team. I would like to give a special thank you to my mentor, Dr. Dinh, for offering her endless guidance during this project. This concludes my presentation. Thank you.
Hello, everybody. My name is Robert Maslak. I'm one of the current PGY3s at Mayo Clinic Rochester, and my presentation today is lifetime cost and quality-adjusted life years across management options for small and medium-sized sporadic vestibular schwannoma. I have no commercial relationships to disclose, but some internal funding was utilized to perform this project. So a little bit of background on the subject. As outlined by Dr. Marinelli earlier, initial observation of vestibular schwannoma has become increasingly popular as a management strategy as the natural history of vestibular schwannoma has been further defined. Specifically, we've noted a saltatory growth pattern where a number of tumors will enter a period of quiescence where they won't grow for long periods of time. Also of note, quality of life studies have shown equitable results between management strategies, specifically MRI surveillance, upfront radiosurgery, and upfront microsurgery for a number of different domains. Given this and a host of other factors, there's largely then a limited consensus regarding the optimal management of small to medium-sized vestibular schwannoma. In light of that, a number of different factors could be considered when deciding on a management strategy. One of them could potentially be healthcare costs. However, despite the overarching emphasis on healthcare costs in the United States, the data within the VS realm is relatively sparse. So from this, we asked the question, what is the most cost-effective management strategy for sporadic vestibular schwannoma? With our hypothesis being that upfront definitive management is the most cost-effective, in particular for younger patients. To answer this question, we formulated a Markov model with theoretical patients. Those theoretical patients had small to medium-sized sporadic vestibular schwannoma and functional hearing at the time of presentation. Briefly, a Markov model is a simulatory model in which patients enter various health states. And then after a set period of time within the model, in this present study that was 12 months, they either stay in that specific health state or move to a different health state based on certain transition probabilities. In this study, we had patients enter 4 different management algorithms: initial observation followed by either radiosurgery or microsurgery, and then upfront radiosurgery or upfront microsurgery. We then defined the most cost-effective management strategy in a couple of different ways. One of them was lifetime cost, which is the total cost incurred over a lifetime of care. The other being quality adjusted life year, which is basically a combination of life expectancy and quality of life, and represents the total number or the expected number of years a patient might be free of disease burden after entering a specific management algorithm. If there was a discordance between those two, we then calculated the incremental cost effectiveness ratio, or ICER. Our benchmark for an ICER was $100,000. So if something, say, had a higher cost, but also a higher quality adjusted life year, but that calculated ICER was less than $100,000, we still viewed that as the more cost-effective management strategy, even though it costs more. The parameters for the model were defined from available literature for vestibular schwannoma less than 1.5 centimeters. Costs were defined from CMS fee schedule for relevant diagnoses and procedures. Age at entry to the model varied, as you'll see here shortly, and then sensitivity analyses were also performed to further define the most cost-effective management strategy. Briefly, these are some of the parameters we utilized to formulate the model. I'd like to draw your attention to the cost of the procedure. As you can see, it is quite high for microsurgery and radiosurgery. Another thing to note here is the frequency of monitoring. This did differ between the 3 management options, was based off of a Delphi consensus study that came out last year. To further drive home the point of these patients going through the model, I'd like to present some patient examples. So this is a patient that was diagnosed at, say, age 50, underwent MRI surveillance throughout their lifetime until their death at age 75. As you can see here, this is the total cost incurred throughout their lifetime. This is a patient that underwent initial observation, but then underwent radiosurgery when growth was noted, and you can see the corresponding increase in cost. And this is a patient that underwent initial observation with the corresponding increase in cost associated with microsurgery. So then moving on to the results, this is our base model here, just entering patients into the model at different ages. As you can see here, though, no matter what age patients entered the model, the most cost-effective management algorithm was wait and scan followed by radiosurgery for growth. The next least costly was wait and scan followed by microsurgery for growth. Another thing to note here too is the substantial difference between the most cost-effective and least cost-effective management options at 18 years versus 70 years. So it's a lot closer here at the younger ages as compared to the older ages. The most cost-effective strategy, again, MRI surveillance followed by radiosurgery, did not change with further sensitivity analyses with the changing of parameters is listed here. So in conclusion, we feel as though these data support initial observation with subsequent radiosurgery being the most cost-effective management algorithm on a population level, with observation with subsequent microsurgery being the next. We showed in the Markov model that cost benefit increases with age, in particular, being substantially higher in a 70-year-old as compared to an 18-year-old. And we feel as though that quality of life benefit from the initial surveillance might be due to a period of preserved function. In total, we feel as though these data support that trend towards initial observation in the sporadic vestibular schwannoma patient population, again, acknowledging that there's a lot of different factors that might be at play. These are my references. I'd be happy to take any questions after the session or offline. Thank you very much.
Hi, everybody. My name is Alexander Lurie, and I'm one of the first-year fellows at the Michigan Ear Institute. Today, I'm going to be talking about, excuse me one second. This is not the right talk, which is embarrassing. I will fix it. Sorry about that, everybody. I'm Alexander Lurie again. I'm one of the first-year fellows at the Michigan Ear Institute, and today we're going to be talking about complications after surgical salvage for vestibular schwannoma following failed stereotactic radiation. I don't have anything to disclose. So salvage surgery for vestibular schwannoma is a technical challenge and a challenge for medical and surgical decision-making. Historically, a history of radiation was thought to portend poorer facial nerve and hearing outcomes, but more recent reports do not necessarily support this. Overall, data are lacking because this surgery is uncommon. The aims of this talk are to evaluate complications and outcomes following salvage surgery for vestibular schwannoma, to review the incidence of radiation failure in vestibular schwannoma, and to understand the shortcomings of available data. This was a retrospective review of patients over 18 years of age undergoing surgery for vestibular schwannoma at 2 tertiary otology referral centers. We started by reviewing 1,200 records and were left with 570 patients meeting inclusion criteria, 16 of whom had previously undergone radiation. These patients, most of them had undergone gamma knife, 2 had undergone cyberknife, and 1 fractionated radiotherapy. The average time from stereotactic radiation to salvage was 3.6 years, ranging from 1 to 13 years. Patients who did undergo salvage surgery, who had a history of stereotactic radiation, were older on average and more likely to take anticoagulants, but had no significant differences when compared to patients undergoing primary surgery in gender, BMI, history of hypertension or diabetes, tumor size, surgical approach, or the use of a planned staged resection. Patients undergoing salvage surgery were less likely to achieve a gross total resection, with only 31% of these patients achieving a GTR compared with 56% of patients undergoing primary surgery. Looking at complications, patients undergoing salvage surgery were at significantly higher risk of CSF leak when compared to patients undergoing primary surgery, and were also at higher risk for the development of any complication or the need for revision unplanned surgery within 6 months. These 2 issues on the right were primarily driven by the increased rate of CSF leak because in the salvage surgery group, CSF leak accounted for 67% of all complications and necessitated 80% of all unplanned surgeries. There were no significant differences in pre or post-op facial function between patients undergoing salvage surgery and primary surgery. A multivariate analysis revealed that previous stereotactic radiation was associated with an increased risk of CSF leak with an odds ratio of 4.2, independent of age, tumor volume, BMI, gender, or surgical approach. Salvage surgery after failed radiation for vestibular schwannoma is challenging to study, partially because radiation failures are rare. According to most literature, they occur in about 5% of cases. This is complicated by the fact that the definition of failure is variable, sometimes defined by authors as progressive tumor growth on 2 or more post-radiation studies, sometimes as continued growth a number of years after radiation, and sometimes as the requirement for further treatment. In addition, 30 to 50% of observed vestibular schwannoma will not grow over the course of 4 years, and this statistic is not taken into account when evaluating success rates of stereotactic radiation. In total, long-term data are limited, leading some authors to suggest that rates of salvage surgery will eventually increase. Radiation disrupts the proliferative phase of tissue formation, specifically granulation tissue formation and neovascularization, and has many known deleterious effects on wound healing in many surgical fields, including in head and neck oncology. It's actually also a known risk factor for CSF leak after anterior skull-base surgery, for instance, if a pituitary tumor is irradiated prior to resection. While numerous studies have investigated salvage surgery in vestibular schwannoma, previous work specifically looking at CSF leak in this setting is limited. 2 prior studies which did report this statistic did not show any association between CSF leak and a history of radiation. With regard to radiation in the facial nerve, in the early 2000s, small reports did suggest an increased risk of facial weakness in salvage surgery for vestibular schwannoma compared with primary surgery, although more recent reports have not necessarily supported this, allowing for an incomplete or less aggressive tumor resection in the salvage setting. We report similar results in this study to these more recent reports. The greatest limitation to this study is our sample size. We investigated a total of 16 patients who underwent salvage surgery, and our assertions about the increased risk of CSF leak are based on only 4 events. We did have the potential for selection bias, as this is a retrospective study, and we do not know the decisions that went into radiation being selected as a primary therapy for certain patients, and we made no distinction between different forms of radiation, although no data exists that suggests different forms of radiation affect tissue differently. So from this study, we conclude that patients undergoing salvage surgery were at higher risk for postoperative CSF leak than patients undergoing primary surgery. As in other contemporary reports, facial nerve outcomes were not significantly different between patients undergoing salvage and primary surgery, but further study with larger samples, particularly with multiple institutions contributing, would be very beneficial to elucidate this further in the future. I'd like to thank my co-authors and mentors at the Michigan Ear Institute, as well as the ANS for allowing me to speak to you today. Thank you very much.
Hello, my name is Bridget McDonald. I'm a medical student at UC San Diego. It's an honor to discuss with you today our experience with delayed facial nerve palsy following surgical resection of vestibular schwannoma. And neither myself nor my co-authors have any disclosures. Facial nerve palsy continues to be a significant source of morbidity after resection of vestibular schwannoma. Many previous studies focus either on immediate or overall facial nerve palsy, and less is known about the nature of delayed facial nerve palsy. The precise definition of this phenomenon varies, but it's commonly described as a postoperative deterioration of at least 2 House-Brackmann grades after postoperative day 1 or 2. Recent work suggests an overall incidence of this ranging from 10 to 25%, and luckily prognosis remains favorable for these patients. Identifying risk factors for delayed facial nerve palsy has been challenging. One paper found that patients with higher rates of gross total resection and retrosigmoid surgical approach were more likely to encounter this, yet other studies have found no differences in these characteristics. And similarly, factors such as tumor size or intraoperative electromyographic metrics have yielded ambiguous findings. So this study examines clinical and surgical characteristics of patients who develop delayed facial nerve palsy compared to those without facial nerve dysfunction throughout their course, with the goal of describing delayed facial nerve palsy incidence, characterizing possible factors associated with its development, and then describing the postoperative course for these patients. We prospectively collected data from consecutive patients undergoing vestibular Schwannoma resection from November 2017 to August 2020. Patients were excluded who had poor facial nerve function prior to surgery or fewer than 30 days of follow-up. At the conclusion of each case, a 0.05 milliamp stimulus was applied to the root of the facial nerve, and responses exceeding 100 microvolts were documented as an excellent response. The House-Brackmann scale was used to grade facial nerve function, and delayed facial nerve palsy was defined as deterioration of facial nerve function of at least 2 House-Brackmann grades between post-op day 2 through 30 in patients with pre-op House-Brackmann 1 or 2 and immediate post-op Brackmann less than or equal to 4. In addition to clinical visit data, a previously validated 2-item questionnaire regarding facial function was distributed to achieve most recent follow-up data. In total, 288 patients met inclusion criteria with a mean age of nearly 48 years and approximately 36% male patients. Mean maximum tumor diameter was just over 19 millimeters. Surgical approaches were well represented with approximately half translabyrinthine and 1/4 middle cranial fossa and retrosigmoid respectively. Nearly 3/4 of tumors were removed with gross total resection. In all cases, the facial nerve remained anatomically intact, and over 93% of cases demonstrated an excellent intraoperative EMG response at the conclusion. When examining differences between patients with delayed facial nerve palsy versus those with no facial nerve palsy throughout their course, those with delayed facial nerve palsy, on average, had larger maximal tumor diameter, a lower rate of retrosigmoid approach, higher rate of translabyrinthine approach, lower rate of gross total resection, and lower rate of an excellent intraoperative facial nerve response. These variables that displayed a significant difference were then included in a multivariable binary logistic regression analysis to examine associations with the development of delayed facial nerve palsy. Once these characteristics were all taken into account, only an excellent intraoperative Sorry for that hiccup. I think we're back. Once these characteristics were taken into account, only excellent intraoperative EMG response showed significance, with these patients being 72% less likely to develop delayed facial nerve palsy. In total, delayed facial nerve palsy occurred in 31 or 10.8% of these patients, with a mean time to onset of 8.1 days, ranging from 2 to 28 days. This figure depicts the House-Brackmann course of these 31 patients represented on the vertical axis, and time is represented on the horizontal axis, specifically prior to surgery at each of the 30 post-operative days, and then at latest available follow-up on the far right. And we can see that by latest available follow-up, 71% of these patients have recovered House-Brackmann 1 or 2, and an additional nearly 10% have recovered House-Brackmann 3. As a secondary measure, with those 31 patients who developed delayed facial nerve palsy, we conducted an iterative correlation analysis of House-Brackman grade at each postoperative day with House-Brackman grade at latest available follow-up. Here, the goal is to assess which point in the 30-day postoperative course might be best to prognosticate eventual House-Brackman grade. We found that the strongest correlations were seen on post-op day 3 and at approximately 1 month. In contrast, there was not a significant correlation preoperatively or at post-op day 1 or 2. So in summary, of these 288 total patients, approximately 11% developed delayed facial nerve palsy, and of these, most, 81%, developed recovered House-Brackman 1 through 3. Intraoperative EMG facial nerve response, tumor size, surgical approach, and extent of resection may play a role in the development of delayed facial nerve palsy, particularly those with excellent facial nerve response to low amplitude stimulus were less likely to develop delayed facial nerve palsy when other factors were considered. In those who do develop delayed facial nerve palsy, House-Brackman grade at 1 month was strongly correlated with long-term function, although patients can continue to improve well beyond that time point. Thank you so much.
Good afternoon. My name is Matt Wu. I'm a fourth-year medical student at Loyola Stritch and a research fellow at Mass Pioneer. I want to thank the ANS for giving me the opportunity to speak today. The title of my talk is called A Subset of Intracanicular Vestibular Schwannomas Demonstrates Minimal Growth Over a 10-Year Period. And I have no disclosures. To start with some background, vestibular schwannomas are benign tumors with Schwann cells that originate from cranial nerve 8. And when symptomatic, patients may present with hearing loss, tinnitus, or balance disturbances. When we look at the prevalence, it may be as common as 42 per 100,000 people. And due to increasing availability and resolution of MRIs, this improved our ability to diagnose small, asymptomatic vestibular schwannomas within the internal auditory canal. And as a result, it's likely that management will be focusing on these types of tumors. And for management, there are two main approaches. First, it's treatment through radiation and surgery, and second is surveillance. But the main question is the timing intervention, because sometimes patients may undergo years of observation while ever having treatment. So it would be extremely valuable to provide prognostic information at the time of diagnosis. So in our study, what we wanted to do was look at small intracanicular vestibular schwannomas and examine growth predictors, because providers and patients are often faced with the question of whether to treat or to undergo observation. In our study design, it was a retrospective analysis done over the course of 2 decades at 2 tertiary care centers. For inclusion criteria, it was at least 2 consecutive MRIs before treatment. And exclusion criteria was having CP angle involvement at baseline or neurofibromatosis 2. We also want to look at the timing of treatment. And our primary outcomes were to understand which intracanicular vestibular schwannomas demonstrate growth and which demonstrate treatment. So after we identified our sporadic vestibular schwannomas, we then retrieved all MRIs, only those prior to treatment, if applicable. We then identified the baseline MRI as the first available MRI. We then divided the tumors in 2 different ways. First, based on their baseline sublocalization in the internal auditory canal. To do this, we divide the internal auditory canal into thirds or tertials. Here's the porus, the midpoint, and the fundus. We then characterize which tertial they were involved in at baseline. We also look at the baseline size, and here there were 3 different groups. We also performed a volumetric analysis using 3D slicer to evaluate our growth outcomes. Here, we contoured the axial cross sections of the vestibular schwannomas. We then get a 3D image with a measured volume. And for growth, we had 2 primary metrics. First, it was interval growth rates measured in cubic millimeters per year. We looked at 3 different time points, 0 to 3 years, 3 to 5 years, and 5 to 10 years. And this was calculated as taking the difference in growth volumes divided by the elapsed time in years. We also looked for the presence of significant growth, which is defined as a 20% increase between baseline and follow-up. And these are our results. We identified 99 intracanicular vestibular schwannomas. The majority of patients were female. The mean age was 54.6 years, and the mean follow-up was 6.1 years. When we look at the distribution of tumors at baseline, we found that the most common location of tumors was involving the fundus, and the two most common sublocalizations was entirely in the fundus and involving all three tertials. Notably, none were entirely localized to the midpoint of the pores. When we stratified by size, the most common size was less than or equal to 100 cubic millimeters. And for those that are less familiar with volumetric measurements, 100 cubic millimeters has a diameter of 5.7 millimeters if we are assuming a perfect sphere. And for 200 cubic millimeters, it has a diameter of 7.3 millimeters. When we looked at interval growth rates and stratified by size, we found that before 5-year follow-up, there were no significant differences. However, after 5-year follow-up, we saw that those that were less than or equal to 100 cubic millimeters grew significantly less than their larger counterparts. We also wanted to understand and evaluate which patients would likely undergo significant growth over the course of follow-up. And it turns out that 2/3 of patients had significant growth, or for nearly all of them, it occurred in the first 5 years. When we stratified by size, it appeared that size did not affect the probability of having significant growth. But when we stratified by tumor sublocalization, it appears that those in the fundus had a lower probability of significant growth compared to those in the midpoint and the fundus. And those in the fundus had a similar probability of significant growth compared to those in the midpoint of the pores. We also evaluate which patients underwent treatment, and it turns out that under 1/3 of patients underwent treatment. And in patients with significant growth, 38% of them underwent treatment. And when we stratified by size, it turns out that size did not affect the probability of undergoing treatment, similar to our growth analysis. However, when we stratified by tertial sublocalization, this proved to be an important factor, in that those in the midpoint of the pores had a lower probability of undergoing treatment compared to those in the midpoint of the fundus. And like our growth analysis, those in the fundus had a lower probability of undergoing treatment compared to those in the midpoint of the fundus. So in conclusion, location and volume may be helpful predictors of intracanalicular vestibular schwannoma growth, where specifically fundal tumors and those that are less than or equal to 100 cubic millimeters demonstrate little growth. These are my references. I want to thank my research team for their incredible support and guidance, specifically my mentors, Dr. Jung, Kozen, and Remenschneider. Thank you.
Hello, my name is Alvin de Torres, staff otologist at the Ear, Nose, Throat, and Plastic Surgery Associates in Orlando, Florida, and previous otology fellow at the University of Utah. Thank you to the ANS for allowing our group to present our findings related to frailty and advanced age on morbidity following vestibular schwannoma surgery. We have no relationships to disclose. As we're all aware, vestibular schwannomas are benign neoplasms of cranial nerve 8, which are managed either with watchful waiting, microsurgical resection, or stereotactic radiosurgery. Compared to younger patients who are often offered surgery earlier, in older patients, observation is preferred unless tumor size, hydrocephalus, or debilitating symptoms occur. And when those are present, surgery or radiation is considered. And for fitness for surgery is often determined based on a clinical gestalt of the patient, presence of comorbidities, or perceived anesthetic risk. When examining outcomes in acoustic surgery related to age, the literature is mixed. The literature is mixed, with some studies showing worst outcomes, such as increased length of stay, mortality, and complications attributable to age. However, others show no difference in outcomes compared to younger patients. With improvements in neuroanesthesia and geriatric care overall, other cranial surgeries have been performed in much older patients with good outcomes. An explanation as to why some older patients do well while others do not may likely be due to frailty, which is defined as a decreased physiological reserve due to comorbid conditions. Other surgical fields have begun using metrics of frailty to help predict surgical fitness and likelihood of complications to help aid in decision-making and counseling. One such frailty metric is the 5-factor Modified Frailty Index, or MFI. This is derived from factors present within the National Surgical Quality Improvement Program database, or NSQIP. These factors were determined to be important based on a large population study on aging, and the MFI is scored from 0 being robust to 5 being severely frail. Our study objectives were twofold: using the NSQIP database to determine the relationship between frailty using the MFI and 30-day postoperative morbidity using a univariate and multivariate model. Number two was to assess the impact on advancing age, i.e. patients in their 70s and 80s, and comparing their outcomes to patients in their 60s. The database was queried from 2005 to 2018. We used procedural codes associated with vestibular Schwannoma surgery and were filtered by the diagnosis code for benign neoplasm of cranial nerves as the reason for surgery. Patient demographics, MFI factors, and the occurrence of a postoperative medical complication as defined by the NSQIP were obtained. These include infections, respiratory failure, stroke, and MI, among many others. The query retrieved 1,856 patients, a majority of whom were robust or non-frail with an MFI score of 0 in 1,200 patients. Roughly 500 had only one factor for frailty, 119 had 2, 10 patients had a score of 3, and only 1 patient had a score of 4. As you can see, MFI correlated with complication occurrence with a 35% increase in chance of a complication with each 1-point increase in MFI score. However, in a multivariate model, MFI only approached significance while age was a statistical predictor. No other factors in this model were significant. This finding may be due to a skew in the data where the majority of patients were both young and robust, and the number of patients overall in the higher frailty groups was comparatively low. When comparing older versus younger patients, older patients had a significantly higher rate of morbidity at 26.7%, while younger patients experienced a complication rate of 17.7%. There were 292 patients in the older than 65 years category, while there were over 1,500 patients who were younger. In general, older patients had a mean MFI of less than 1, suggesting general robustness. We did want to see if complication rate changed with additional increases in age in the advanced age group overall. And when we looked and compared the advanced age groups, the rate of complications was statistically similar. Further, there was no statistical difference in MFI score among the different age groups. There are limitations to our study. While we expected the frailty to correlate more strongly with complications, an explanation for the lack of this finding is the possibility of sampling bias, as there were very few patients who were both old and frail included in the data set, while the vast majority were young and robust. As we used the NSQIP predefined complications such as MI, stroke, or infection, another limitation is that the data doesn't include complications of interest such as CSF leak or facial weakness. Finally, while the data set was robust for a complication rate overall, the data set is underpowered for looking at individual complications. In summary, we think that both age and frailty are important factors in considering surgery. We found that frailty correlates with post-op complications in a univariate model. However, age becomes more important when considering other factors. In comparison to other findings in the literature, other authors have found frailty correlates with increased length of stay while age does not. To our knowledge, this is the first study comparing complications in patients in their 60s, 70s, and 80s. Despite a higher complication rate in patients younger than 65, there's no difference in complication rates among the different advanced age groups. Given this finding, surgery can and should still be offered in robust or non-frail patients in their 70s and 80s, as they will experience similar complication rates to those in their 60s. Thank you to my co-authors and the ANS, as well as the audience for your time. Thank you.
Good afternoon, everyone. Once again, my name is Elizabeth Perkins, and this afternoon I'm going to be speaking about the influence of extent of resection in tumor morphology on facial nerve outcomes following vestibular Schwannoma microsurgery. I do not have any disclosures. So historically, the goals of microsurgical resection have been complete tumor removal and facial nerve preservation, but oftentimes these two goals can be competing, particularly in larger tumors, and when that plane between that facial nerve and that tumor capsule is difficult or sticky, and this places the facial nerve at greater risk for injury. But more recently, there's been a trend towards near total or subtotal resection to help improve facial nerve outcomes. And we all know that facial nerve paralysis has not only functional but psychological morbidity. And patients with facial nerve paralysis have reduced quality of life and increasing rates of depression. And there have been many tumor characteristics that have been associated with poor facial nerve outcomes. So this includes ventral extension, a fluid fundal cap, a cystic component of the tumor, and of course, tumor size. So this has led us to ask the question of how does the extent of resection and tumor morphology influence short and long-term facial nerve outcomes? So we performed a retrospective chart review of all of our patients who had vestibular schwannoma microsurgery over a 10-year time period. So our patients either had a translating or remote approach. And we defined gross total resection as complete tumor removal intraoperatively and complete tumor removal confirmed on the immediate postoperative MRI. Near total resection was defined as the surgeon left, or is visible to the surgeon that a piece of the tumor, small tumor capsule, was left, but this was not visible on the immediate postoperative MRI. And of course, subtotal resection, tumor remnant left intraoperatively and visible on the postoperative MRI. Tumor morphological characteristics were measured in IMPACTS, our radiographic system at Vanderbilt, prior to this year, and that includes our volumetric analysis, ventral extension, and fundal cap. We used the House-Brackmann's grading system to determine our facial nerve outcomes immediate postoperatively and up to 1 year. And it's important to know for the remainder of our talk that good facial nerve function was defined as a House-Brackmann score 1 and 2, but poor function was defined as a 3 to 6. We then used a single predictor and a multivariate analysis to analyze our data, and including a subset analysis called propensity score matching. We use this to really account for the confounding variable of tumor volume, and I'll get into that later in my talk. So initially looking at the demographics of our patients, 75% of patients had a translabyrinthine approach, 82% had a gross total or near total resection. We combined the gross total and near total groups to allow for binary comparison. Overall, we had 384 patients and the mean tumor volume was 2.65 centimeters. So this figure represents the trajectory of improvement in facial nerve outcomes from 3 weeks on the left-hand side to 1 year on the right-hand side. So at 3 weeks postoperatively, 63% of patients have good facial nerve outcomes, and at 1 year, 80% had good facial nerve outcomes. So initially looking at our single predictor analysis results of poor facial nerve function at 2 to 3 weeks and at 1 year, characteristics or variables that were associated with poor function at 2 to 3 weeks was a retrosigmoid approach, tumor volume, brainstem compression, and ventral extension. But the only characteristic noted here that was significant for poor function at 1 year was ventral extension. And interestingly, in a single predictor analysis, subtotal resection was not correlated with diminished facial nerve function at 2 to 3 weeks postoperatively. However, in our multivariate analysis, which included both subtotal resection and tumor volume, patients with subtotal resection were less likely to have diminished facial nerve function at 2 to 3 weeks postoperatively, and this is independent of tumor volume. So since subtotal resection patients were more likely to have larger tumors, we then used propensity score matching to account for that tumor volume. So we had 65 patients with subtotal resection who were matched to 138 patients with gross total resection. In that setting, the subtotal resection remained protective at 2 to 3 weeks postoperatively, even after accounting for our tumor volume. But it's important to note that there was no significant relationship between extent of resection and facial nerve function at 1 year. So overall, we concluded that subtotal resection was associated with favorable immediate facial nerve outcomes compared to gross total resection. Larger tumor volume and greater ventral extension was associated with poor short and long-term function, and there is no relationship between fundal cap and facial nerve outcomes. So like all study, we have our limitations. And the first, of course, is that this is a retrospective study. There's inherent variability in House-Brackmann grading systems, even between providers. And there's also variability in our subtotal, near total, and gross total definitions, not with our institution in the study, but to allow comparison of our study to others. And of course, there's always a bias for tumors that undergo gross total resection. So sometimes they're smaller, or just those tumors tend to have an easier facial nerve tumor capsule interface. And all of our statistics where we look at those who have poor function at 1 year, that 20% is a small number. And of course, those statistics should be interpreted with caution. So of course, I'd like to thank my wonderful team that's made all this work possible, and the ANS once again for having me speak today. Thank you.
Hi, everyone. Thank you so much for those excellent presentations. We are now in the discussion part of the hour, and we have been given a few extra minutes to actually have 10 minutes of discussion. We are going to format the questions in order of speakers. So we are going to start with Dr. Marinelli. There was a lot of questions for Dr. Marinelli, and we will try to group them. There was several that were speaking to how the tumors were measured, volumetric versus linear, and how you decided on 2 millimeters versus greater than 2 millimeters to determine growth. And the third part of that is, how can you discuss how the hearing and facial nerve outcomes were related to the growth patterns that you saw? So you can go ahead and get started.
Okay. Yeah, I thank you very much for just everybody's interest and all the questions. There was a bunch of really good questions. I'll do my best to try and give some reasonable response. I do want to clarify just at the start that we don't mean by any means that we're not suggesting to observe every tumor by these data. We're not suggesting to observe every growing tumor. Instead, the purpose of what really we were trying to do with this study is present a new or novel idea about how to think about observation a little bit differently, where in select cases, you might consider observing a tumor, for example, or continue observing a growing tumor, for example, vestibular schwannoma in an only hearing ear, a small tumor in a large patient. We're not suggesting to observe a large tumor with compressive symptoms, for example. Now, the questions that surround when is too much observation a bad thing? When does it lead to deleterious clinical outcomes? It's admittedly a little bit outside the scope of this current idea. Just we really wanted to focus on what happens with the natural history, but we do have a paper coming out that much more specifically looks at that exact question. And just to give you the punchline of that paper is that when tumors start to grow into the range of about 1.3 to 2 centimeters in the angle, so not IAC tumors, but CPA tumors, but once it grows into that threshold range, we start to see a pretty significant decline in important clinical outcomes. For example, maintaining House-Brackman 1 facial nerve function, not grouping 1 and 2 together, but maintaining 1 House-Brackman facial nerve function. But that paper's forthcoming, and we talk about that topic a little bit more in there. Regarding the linear tumor measurements, there were a couple comments on volumetric versus linear. I guess I'll start by just clarifying that this study was based on linear tumor measurements. We did publish a paper back in October in ONN on this exact same design, only done at our center at Mayo Clinic, looking at volumetric tumor growth, natural history of volumetric tumor growth. Speaking to that, there was a really insightful comment about how linear growth changes as tumors become bigger, and the importance of considering the 3-dimensional impact of a CPA tumor. Interestingly, in that study that we looked at, just at volumetric tumor growth, we actually, even though volumetric measurements are more sensitive, we actually found that less tumors grew over time. Granted, that was single center data, less patients, but so we did look at that, and we fleshed that out a little bit more in that paper that I said was published in the fall. The question about 2 millimeters, Based on, it's to the best of my knowledge, 2 millimeters is the most common cutoff used as a litmus for detecting true interval change in tumor growth. For instance, the 2003 Tokyo consensus guideline published in ONN uses that as a litmus, and it's based on several different studies, but mainly just that between rescan variability and just patient positioning and different sequencing factors, that 2 millimeters is a pretty good litmus. 3 millimeters is of course also very reasonable. The one thing I'll just mention, if we would have used 3 millimeters, we would have obviously had less patients included in the study, but also that's a more lax growth criteria. So even, we said about a third of IAC tumors and a fifth of CPA tumors didn't have any subsequent further growth. That presumably that number would be even higher, that do not continue to grow if we would have used 3 millimeters. It's my best response at some of those questions. Please let me know if I missed anything or if there's any further questions.
Thank you. There is a lot of interest in this, but in the interest of having participation for the other speakers, we're going to move on. And I invite people to reach out to Dr. Marinelli with subsequent questions. We had a question from Dr. Hoa regarding, for Dr. Misztal, regarding the phospho-HDAC expression. Would you like to answer that?
Yeah, sure. Thank you for the question, Dr. Hoa. That's a great question. So we typically collect DNA from blood leukocytes from our patients as part of our tumor banking protocol, but we don't routinely collect RNA or protein. And we weren't anticipating such a strong relationship between phospho-HDAC2 expression and AR42 response. So we have not looked at that yet, although that's definitely an interesting direction to move towards in the future as we try to develop more precision medicine-based treatment protocols for NF2-associated schwannomas.
All right. Well, thank you for that. Can you comment on the clinical implications of this? Like, what would be your next steps?
I think our next steps are definitely addressing the limitations of our study, perhaps trying a different xenograft model to see if we can get regression of tumor or slow down the progression of tumor in our rats. Other studies have been able to show this in a sciatic nerve model of a mice, so we hope to reproduce that and anticipate the results of the phase 0 study.
Okay. Thank you, Carly.
Thank you.
All right, we have just a few minutes left. I don't see any other questions on the board for some of the other speakers. I did have a follow-up question for Dr. Marinelli. Did you notice a trend in that study regarding which tumors were more likely to experience growth, whether in just speaking in terms of the small, medium, large categories? I don't remember seeing that in your presentation.
Thank you. That's a good question. Kind of like what was presented from the Mass Pioneer data. This study, several other studies, as well as the previous one I talked about volumetric growth, tumor size was kind of loosely correlated with being predictive of future tumor growth. Really, the only thing that bore out in any much significance, not talking clinical significance, but I mean, not talking statistical significance, but more clinical significance. The only thing that really bore out was this idea that the magnitude of interval growth detected from the diagnostic scan to the scan that detected initial tumor growth, that seemed to be, based on our data, based on this initial study, the most predictive feature of whether or not a tumor was going to continue growing. And as I briefly alluded to in the talk, that probably that has something to do with something pathophysiologically going on where something's going on where it creates a setup for that tumor to have significant growth, that likely biochemically, or it's a setup for that to continue to happen over time. That's how we've reasoned with it, but not entirely sure.
All right, thank you. I think we're almost out of time here. So I'd like to thank everyone again for attending. Please know that we have another great panel coming up on lessons learned. So we invite you to please join us for that.